Many years of experience treating ACLs. And what are the keys to successful ACL surgery and recovery? Here are my disclosures. So over the 2,000 plus ACL reconstructions I've done over the past 18 years, I've treated a wide range of athletes and non-athletes, but from the pediatric to the older, competitive to recreational, and high school to the professional. So there's a lot of considerations. There's the preoperative considerations that help make successful outcome, operative, postoperative, and return to play. You can see the operative is only one small part of it. It's all these other parts that really make a big part of it. So it begins with initial treatment. We want to get that knee feeling well. That person hurts their ACL. We want to do the prehab. We want to reduce the swelling. We want to get motion and get the quad going. So reduce that swelling. We'll do the typical things with ice, compression, anti-inflammatories, but sometimes we'll aspirate it, and that can be very helpful with a big swollen knee to get that knee calmed down. We want to get that motion. We want to get that extension preoperatively. We want to get that flexion preoperatively, and then start some quad strength. Don't wait till after surgery. We want to do that now. I've seen the best outcomes come when the patients really look great going to surgery. In fact, they don't even want surgery because they feel so good, but they still need it. And then that's Rob. I knew you were working on your quads, Rob, but just want to make sure that the audience knows, because you are a strength and conditioning coach. I know that was back in years ago. So get the knee feeling well, prehab. The better you are going into surgery, the better you are going out of surgery. And I tell my patients that all the time. So we get that. Now, what about making the right diagnosis, the right portion of the operative? So before we do surgery, we want to make sure we know everything that's going on. We want to make sure that we know of any associated injuries, posterior lateral, ligament injuries, posterior medial, meniscus, cartilage. We need to understand what's going on. That's going to help us in their recovery. So what about the right graft for the right patient? Looking at all these years, certainly you see a lot of things that work, you see some things that don't work. So my ACL graft preferences, and there's a lot of ways to do ACLs, but my graft preferences in the skeletal mature young athlete is a patella tendon. In the collegiate and professional athlete, it's a patella tendon. A hamstring in a 20 to 50-year-old recreational athlete, and then maybe a combination graft, which would be one hamstring plus a cadaver in the 40 to 70-year-old. I've just seen in those younger athletes, the ones that are skeletal mature, that the patella tendon just seems to hold up the best. And in the college and professional athletes, just has a great track record. So certainly some preferences, all the different grafts work. The one graft that does not work in the young patient is the allografts. So that is the wrong graft for the young patient. This is Chris Kading's work that came from the Moon group that we're part of, looked at the different failure rates, and in those aged less than 20, using an allograft had an exceptionally high rate of failure. So that is the one thing that I do not want to use in my young patient. Now, intraoperatively, we got to have the correct tunnels. The correct tunnels are critical. The far left picture shows the tunnels that are not in the right place. The ones on the right show the ones that they are. This tunnel is too far anterior. This one's right in the middle. This is the one step of the surgery that the surgeon controls that can have a huge outcome on the surgery, and if it's done correctly, it'll be great. If it's done incorrectly, already you're starting at a bad place. So the correct tunnel position, certainly when I was out starting in training, we used to have our tunnels up here. And then Freddie Fu came along, and we started maybe doing our tunnels down there. And now we've gone back to a place that it was done even early on in the ACL, and that's right about in the middle. But having the correct tunnel position in the right place is going to make a huge difference in the outcome, and we don't want to get started on the wrong track. We want to fix the meniscus when possible, especially the medial. We know that if we take out that medial meniscus and have less medial meniscus tissue, then that's going to have a big stress on the ACL. So we want to have a medial meniscus if we can and keep that intact as much as we can. We want to understand there's lots of ways to fix the ACL, and we want to understand that there's a lot of ways to navigate through that. And you have to be able to do a lot of different tunnels, a lot of different ways, through the anterior medial portal, through an outside in. We just have to be able to do that, particularly in revision surgeries. There has to be a lot of ways to go through. We can't do it the same way every time, particularly in a revision case. What about the tourniquet? I found that avoiding the use of the tourniquet is extremely helpful. paper that came out in 2017 with systematic review shows decreased thigh circumference, delayed quad activation. This was a systematic review looking at that. I don't use the tourniquet unless I have to. Ashley can tell you, my PA, over all the 6 years, she's seen the tourniquet maybe one time to control some bleeding, but it'd be rare if we use it. So try to avoid it. We want that quad firing from day one if we can. So immediately post-operative, we want to reduce the swelling. Same thing we did right after first day of injury. We want to get early PT. We want to get early motion and activated quad. So the same thing when they got injured. We're trying to do the same things now after surgery. I like to reduce swelling, and I do think that these cryotherapy and the compression devices are quite nice. There's certainly Game Ready and then the NICE machine, and you can see this athlete with relaxing after his surgery that these things work great. Really do. So I think these things are terrific because they provide the cold, they provide the compression, and really something that's very beneficial. I want to get this patient in the first couple days. I've seen that's so helpful to get in PT, even if it's just get them out of bed and going, and the PT can't do much. The PT actually is doing a lot. By getting them there, by getting the quad going, by doing maybe a little motion, by getting some muscles firing, that is actually doing something. So getting the patient to do that is huge, and that's why we have them do it in the first couple days. And again, let's get that extension early. Got to get that. Let's get them doing some towel stretches. Let's get them doing things, because if we don't get it early, it's going to be hard to get later. Let's get them on a bike. Great for the knee health. I've seen it so helpful. It's great for the quadriceps. It's minimal stress on the ACL. This was a nice paper done in 1998 by Braden Fleming and the group in Vermont. 8 patients. They actually put these strain gauges on the ACL, just like you see right there. In patients, they put these gauges inside, and here's what they found. The bike had less strain than squatting did. So just remember, the bike is great. It's great for a lot of reasons. It gets the quad going. It has really a minimal strain on the ACL, and it's a really terrific exercise to get patients going on early after the ACL. Again, I'm going to just focus on it. Get extension. If we don't get early, it's harder to get. And I like using little devices. One of the ones that I've seen since even my days at Vanderbilt was a 3 × 10=0 device, straightknee.com. Pretty simple device. You can make it, but it's really a nice device to help patients do it. You do it 3 times a day for 10 minutes, get 0 degrees. If patients struggling, we certainly recommend that. We got to protect the graft early on. This is a great slide. I want you to put this in your memory and look at it. Look at what this is saying right here. This is the revascularization, the remodeling that occurs with an ACL graft. So the graft gets weaker before it gets stronger. It starts really strong. Look at this. At 6 to 10 to 12 weeks, 6 to 8 weeks, it's at its weakest. Do not stress that ACL. Do not allow a patient to twist or turn on it at that 6 to 8 week mark. Look how weak it gets, and then it gets stronger. Again, this is all part of the revascularization, the deorganization of the collagen, the remodeling, and then the maturation. You got to remember, our patients got to remember that. PT should have this little slide with every patient as they're treating them at that time point. Other post-op considerations, don't forget the psyche. Huge. Most patients, athletes have some type of post-injury depression. Now, what about return to play? What is return to play? What is that all about? What does that mean? Is it play, or is it practice, or competition? Needs to be clearly defined. Certainly often open to interpretation with coaches, trainers, players, and parents. We just published this with George Davies, Matt Prevention, myself, and Rob Mansky, looked at the return to sport guidelines and criteria. There's a milieu of factors associated with return. It's just not one factor. It's not just strength. It's just not stability. It's just not the feeling that I'm ready. There's no predictive validity of current studies on return to play ACL, so you take a lot of the information that you get, including the lecture that will come up from Rob, and put these all together, understand as we try to get patients back to return to play. But use a battery of testing, and you look at all the different things with the examination, with the progression of return to sports specific to then more stimulation and sports activities. You got to put it all together as we look at return to play. Go slow, allow that graft to mature. When I first came out, Shelbourne had everybody going, trying to go back at 4 months. That's not the way to do it. You can get your quads, you can get strength back, but you're not going to be ready at 4 months, and the graft is not going to be ready. I'm now looking at 8 to 9 months. I've seen too many people that will fail too early and come back too early. I do like to brace my young patients. I like to brace this college athlete who had the ACL done. I like to brace my college athletes and pro athletes. If it's me and I'm a skier and I get an ACL, I don't care about bracing, but I do think it's important for a number of reasons. We know it's not going to totally protect the ACL, but we do know that that person, if they get hit or any contact, and that having that armor on does help with their psyche. So I do brace them, and I do it for the first year. So lastly, just a couple thoughts. Player confidence. It's essential that the athlete demonstrates sufficient confidence in the affected extremity to successfully return. They got to have the confidence. And that sometimes takes a lot of work. It takes a lot of work for the physical therapists, from the athletic trainers, from the docs. And then lastly, the 3P program. This came from Kevin Wilk: performance, practice, and play. In getting back to sport, we got to start with the performance. As we're getting better, getting training, we're going to do drills, sport-specific drills. You're going to do things. And then we get to the practice situation. It's controlled practice, controlled environment. Gradually increase the time, intensity. We just don't throw them back to practice. We start giving them some time. You do it for 5 minutes. Maybe it's 10 minutes. Intensity increases. And then you go to practice games, to scrimmages. So you just don't throw them back. If you do, then they're going to be in trouble. And then finally, we return to the competition and then get into a game situation that's 100%. So basically, in summary, we try to go through it sequentially. We try to look at performance, looking at practice, looking at play. Look at the preoperative considerations, do the prehab, get the tunnels in the right place in the surgery. Postoperatively, let's get their quads going, let's decrease the swelling, and return to play. No hurry and return to play, the 3 Ps. And now we got Albert Gee from the University of Washington. He's the team doc, and he's here to represent his team today. Come on up, Albert. Albert's he's well respected in the Pac-12, and I'm glad that you could make it a day early.